For this lecture, we're going to talk about the diseases that are specific to the pediatric population. And we're going to start on page 378. Neuromuscular disorders will affect the body in various ways. There are four distinct ways that you may see a neuromuscular disorder affect the muscles of ventilation. You could have a defect in the muscle itself. The disease process may cause there to be a blockage in the transmission of nervous impulses to that muscle. You could have a defect in the peripheral motor and or sensory nerves, or you could have a defect in the central nervous system altogether. Therefore, it will not send messages to the muscles to contract and relax. Now, there's two main spinal muscular atrophy disorders that you need to know. And spinal muscular atrophy just means a wasting away of the muscle that is attached to the spine. So the muscles that cause you to have motion to your movement at your spinal cord, or to the muscles that attach one vertebrae to the other. So the two that are most common are Worden-Hoffmann paralysis and Kugelberg-Wieslander disease. Worden-Hoffmann paralysis is more common in infants because it usually manifests at birth. The most apparent feature is that the baby is, the neonate is born and they're not very active. It is the most common and severe form of spinal muscular atrophy. And the infant lies in a frog-like position with limited movement of the arms and legs. They also have diaphragmatic breathing, which means that you'll see their abdominal cavity go up and down more so than you see their chest cavity. And they also have sternal retractions when they breathe. Their cry and or cough may be weak, and they may also have pooling of secretions in the back of their throat in the pharynx area. And the neonate has an alert appearance, and sensation and intellect are normal, but they will just present with the frog-like type of body shape. The disease is diagnosed with electromyography, and that test will show that there is a denervation pattern from the muscles of the spinal cord. Confirmation of the disease is made by muscle biopsy, and these babies actually do end up dying, unfortunately, due to respiratory failure or some type of pulmonary infection because they are more likely to aspirate. With Kugelberg-Wieslander disease, it is kind of the opposite of what you see with Worden-Hoffmann, because these kids aren't born with the complications. The complications will appear later in childhood or even all the way into adolescence. So it has a slower progression. The first muscles that will be affected are in the pelvic girdle, with the arms and legs starting to have problems later as they continue to have their growth spurts. It is rare for people with Kugelberg-Wieslander disease to have severe complications, so they will end up having a normal lifespan. Now, muscular dystrophies, this is when the muscle tissue is progressively being weakened and will actually waste away over time, just like with spinal muscular atrophies where the muscle tissue has wasted away. This is progressive, kind of like how the Kugelberg-Wieslander was a progressive thing, but with muscular dystrophy, as you probably know, because a lot of people have muscular dystrophy, even into adulthood, they may not be may not have any severe complications. It just depends on the progression of the disease. So, a muscular dystrophy is the largest group of muscle disease that affects children. They exhibit progressive symmetrical weakness and wasting of the skeletal muscles. And the basic defect in these diseases is a degeneration of the muscle fibers, not the actual muscle tissues itself, the fibers that bind them together. The most severe and most common type of muscular dystrophy is Duchenne's muscular dystrophy. It usually appears during the child's 3rd year of life. That's important to remember. It first appears as a difficulty in running, riding a bicycle, or climbing stairs. So usually around that toddler phase is when they start being really active. And because of their muscles starting to waste away, they will start to have difficulty doing these things like running and riding bike and climbing stairs. A later manifestation of the disease will cause a difficulty in walking, with an apparent abnormal gait, ability to stand upright from a sitting position and maintain your balance in walking. And pseudohypertrophy is a name that's derived from an enlargement of the calves, thighs, and upper arms from fatty infiltrations, and that is commonly seen in Duchenne's muscular dystrophy. It states in your text that as the disease progresses, profound muscular atrophy will occur, with ambulation becoming impossible. Once that tissue is wasted away, they will not be able to be mobile again. And if the disease does progress in this manner, it could be terminal. And in its terminal stages, the muscles of ventilation, including the diaphragm, are affected. The last set of neuromuscular disorders we're going to talk about are acquired muscular disorders. We already know about Guillain-Barré, but you need to make sure that you know the other term that the NBRC loves to use, which is called acute infectious polyneuritis. Acute infectious polyneuritis. So nothing different with Guillain-Barré when it's presented in a pediatric patient than what you already know about it from the adult population. Of course, you know it's going to start in the lower extremities and work its way up, ground to brain, Guillain-Barré. So it's the same with the pediatric population. As it states here, the cause of Guillain-Barré is unknown, but the thing about this muscular disorder is that it usually will present when a patient has a history that they've had some type of viral condition prior to the signs and symptoms of Guillain-Barré. So they might have been diagnosed with mononucleosis, hepatitis, influenza, cytomegalovirus, which is CMV. So make note of that a scenario may include in the history that the patient had a viral disease first, and then they started to see that the muscles started to be weak in the lower extremities and moved up, so on and so forth. Okay, so you already know about Guillain-Barré, so let's move on to tetanus. Tetanus is that it will affect your nervous system and your muscles. It is preventable neuromuscular disease caused by an endotoxin called Clostridium tetani. And usually the reason why people get tetanus disease is because they have a puncture wound through the skin. It says wound or puncture wound, but typically you step on or have some type of impalement of something that has been rusted. So, in the neonate, infections may occur in delivery um, if the delivery occurs in a contaminated surrounding. So, it is not uncommon for a neonate to get tetanus, even though they haven't been running and playing and step on a nail or something like that, which is what would typically happen with a toddler or an adult. So the tetanus spores are found in soil and dust and are more prevalent in rural areas. So if the area where the neonate was born into is not very clean, like a manger or something, then they could develop or contract tetanus. Incubation is generally less than 14 days, but could be a little longer. So, depending on the severity of the contamination, will determine how quickly the patient starts to see symptoms. Initial symptoms are progressive stiffness and tenderness of the neck and jaw muscles. Very important to remember. Progression of the disease causes rigidity of not just the neck and jaw, but also the abdominal muscles and your limb muscles. Patient may have difficulty swallowing, extreme sensitivity to external stimuli, and the slightest stimulus could cause a convulsive contraction, and that convulsion can last for seconds up to minutes. As the disease progresses, the patient suffers from laryngeal spasms and tetany of the respiratory muscles. The patient is then predisposed to aspirating, obviously, if they are having spasms of their larynx. They could also get pneumonia and atelectasis because of the aspiration. The disease is best prevented by proper vaccination. So even neonates get tetanus shots. And of course, pediatric all the way up to childhood years, they are given tetanus shots. Botulism is the last neuromuscular disorder that we will discuss. As you will find, there are several of these diseases that you will hear about. There's so many different diseases out there that we're only covering the most common ones you will see in all of these areas. For all of these diseases, pediatric and neonate, there's way more than what we could cover in one term. So I'm just pulling out the most important ones. Okay, botulism is the result of ingestion of food contaminated with Clostridium botulinum, organism. The most common source is if you have a canned good that is not intact. So those canned goods that are dented, grocery stores used to sell them at a discounted rate until they found out that the food contents that could be in that can, because of the dent, because you have messed up the inner workings that the company who made the canned good has maybe sealed the stuff with, because it has been come in contact with something that could have disturbed the inner contents, then maybe air could be getting in, or something could be affecting how it was to be sealed. So if you have a can and it has been dented, don't get the can and open the contents and use it. You're supposed to discard the contents of the can and the can itself, actually. So symptoms may appear quickly, usually 12 to 36 hours following the ingestion. Your book says ingestion, but it's ingestion of the contents of that can. Pediatric patients show signs of weakness, dizziness, headache, difficulty in speaking, and even vomiting. As the disease progresses, the respiratory muscles become paralyzed. Of course, you can have atelectasis if aspiration occurs, and you can have pneumonia. Patient must be monitored closely for signs of respiratory failure. Infants can acquire botulism from the ingestion of spores of Clostridium botulinum. Although there is no common source of the organism, it has been found in honey. So that is why, if you've ever noticed, when you have medication for infants like cough syrup, if it includes honey, it specifically states that the child must be over the age of 1 for this very reason, because infants can actually get the Clostridium botulinum because they have been exposed to honey too soon. So you should not give honey to infants. And of course, an infant is anyone from day of birth up to 12 months of age. The infant patient, if they are exposed to the spores, could become constipated and experience lethargy, and feedings could be poorly tolerated because their intestines has the spores inside of it. Treatment for botulism is to give an antitoxin, which is controversial in infants. And then once you are given the antitoxin, you will just monitor the patient for and support their symptoms that they may be experiencing. Okay, for the central nervous system disorders, we're going to talk about myasthenia gravis, spinal cord injuries, head trauma, near drowning, and Reye syndrome. With myasthenia gravis in pediatric patients, it's really uncommon to have a patient that is of pediatric age to have myasthenia gravis. But if they do, it'll be in two forms, either neonatal myasthenia gravis or juvenile myasthenia gravis. The transient neonatal myasthenia gravis occurs, of course, in infants. And in these infants, usually the mother may not be aware that they actually have the disease. So the neonate will present with myasthenia gravis simply because genetically they received it from mom. They will present as having weakness, having depressed neurological signs, having weak cry, and with persistent neonatal myasthenia gravis, it is indistinguishable between the transient, but it occurs in infants whose mothers do not have the disease. So the way to really distinguish between transient versus persistent is to get a true diagnosis of mom. Juvenile myasthenia gravis is identical to that that you see in adults. It usually appears after the age of 10, and the paralysis, of course, starts from the upper extremities and travels down to lower extremities. So the optic muscles are the ones that start to have the difficulties. Most typically, that's what you see when the patients come in, that they're having problems swallowing and speaking. They will have general muscle weakness that may be more pronounced following exertion, whether it be from exercise or playing or something like that, and then less pronounced when they are at rest. In order to diagnose, we do the same thing that we do with adults. We use the Tinsolin test, or we can do the Tinsolin test by giving Tinsolin indrophonium, so you need to know the different terms, and then neostigmine or prostigmine. And as you know from learning myasthenia gravis with the adult population, what happens when the drug is given is that muscle strength will return, but it only lasts for about 5 to 10 minutes, and then the patient goes back to being weak. that's how you know that they have a positive diagnosis of myasthenia gravis. With spinal cord injuries, we have to be mindful of manipulating the child when moving them from the stretcher to the bed or from the bed to the chair, things of that nature. So when we're moving the patient around, transporting the patient, if they have a spinal cord injury, you have to be mindful of that, just like you do with adults that have spinal cord injuries. You have to know how to secure the spinal cord when you are turning them. So the same that you would do for an adult, you're going to do the same for a child. It is not common that children have spinal cord injuries. However, if you do get an infant or a child that has had some type of trauma to their spinal cord, we will talk about how you can diagnose it, how you're going to treat it, and the role of the therapist. So when diagnosing that the patient has some type of spinal cord injury, you usually will have some type of history related to that. So they will have some type of accident that they are reporting that the child has experienced. Sudden hyperflexion or hyperextension of the neck during an automobile accident is the most common cause of a spinal cord injury. Of course, with pediatric patients, they're likely to fall from objects, trees, horses. During some type of sporting event, they could have some spinal injury. With a neonate, it may be due to them being breached in the womb before delivery. And if they try to deliver the baby in that breech position, then a spinal cord injury can occur. Most typically when babies are breached, they know ahead of time and they opt for a C-section. Sometimes it's not possible. You might prepare for that, but if mom comes in and she is already effaced and a leg is hanging out or arm or something of that nature, if they can feasibly get the baby out, they will. If not, they will try to push the baby back up into the birth canal and then do a C-section. You may also, depending on where you work, if you work in a trauma facility where this is very prevalent, you may have some GSWs, gunshot wounds, and stabbings of pediatric patients. Crazy enough, but it could happen. And also keep in mind that in a pediatric facility, they take patients all the way up to the age of 19. And some specialists that deal with, like pulmonologists that deal with cystic fibrosis patients, they will see patients all the way in their 20s. Okay, for you as a therapist, the injuries that affect the muscles of ventilation are extremely important. So, of course, a spinal cord injury is going to affect the diaphragm's ability to contract and relax. Since the phrenic nerve is what sends the messages to the diaphragm to contract and relax, if you have some interruption in the spinal cord, then the cervical plexus that arises from the spinal cord that sends the message to the phrenic nerve may not send the message down to the diaphragm. The fourth cervical nerve is the main contributor to the plexus, the cervical plexus, with the third and fifth cervical nerves that make the secondary contributions. So they send the messages from the spinal cord down the phrenic nerve to the diaphragm. Injuries at or above this level, so any injury above the fifth cervical vertebrae, anywhere between the third and fifth vertebrae actually, will cause there to be problems with breathing because the diaphragm will not get the messages from the spinal cord. And of course, C1 and C2, if you have any injury to that area, then you have no communication to the rest of the body at all. And those are the patients that are quadriplegic. So injuries at or above this level result in a loss of the use of the diaphragm and the need for long-term ventilatory assistance. So in the metro Atlanta area, those are patients that go to Shepherd Spinal Center and will need to be on a ventilator long-term and will go home with a ventilator and live that way indefinitely. The intercostal muscles are innervated by the intercostal nerves, which arise from the 1st through the 11th thoracic vertebrae. Loss of these nerves by cord injury is not as devastating as a loss of the phrenic nerve, but these patients will lose a portion of the reserve that we all have when the intercostal nerves are damaged. So you have to consider that. These patients will have a restrictive condition because that FRC will be lost. Or it will be lost, but it won't be as normal as it was prior to the injury. In order to treat a spinal cord injury, there are 3 goals that you have to consider. You want to preserve whatever neurological function that the patient may have and then prevent any further neurological deteriorations. So when I talked earlier about securing the spine properly, you have to keep that in mind because that's one of our goals, is to preserve whatever function they currently have and not make things worse. Maximization of the neurologic recovery. So help the patient recover as much as possible of their neurological function that there can possibly be. And the third goal is to prevent intercurrent non-neurological complications. In other words, try to minimize any secondary conditions that could occur. The first thing you should be thinking about is pneumonia. If this patient has some type of spinal cord injury, they're not going to be up and mobile. So lying in the bed and not being able to move about, the first thing you should be thinking as a therapist is to help them prevent getting pneumonia or any other secondary condition that they may have. If this was a spinal cord injury due to trauma, they may have some other wounds, whether it be internally or externally. You want to make sure that those wounds are healing properly, that they don't have any type of internal bleeding going on. Anything related to not related to the spinal cord, but is related to the patient's condition, you have to try to keep those things at bay and get those things back on track so that the patient can heal properly and go home. Okay, head injury is the next CNS disorder we will discuss for pediatric patients. It is estimated that head injuries in children lead over 500,000 hospitalizations a year. Kids just like to jump and play, and hopefully they don't result in head injuries, but as you see here, over 500,000 of them do. Of those 500,000, 3,000 to 4,000 will end in death, unfortunately, and 15,000 will require extended inpatient care. So if you have kids, be blessed that none of them ended up in this condition. But several basic concepts in the care of head injuries may help to reduce morbidity and mortality in these patients. So the pathophysiology that's related to head injury is important to understand that there are 2 things that happen when the brain has been damaged. The first is the primary insult. An insult and injury are 2 terms that are used simultaneously or in conjunction with one another. So when you hear the word insult, think injury. And the primary insult is the thing that happens at the moment that the accident occurs. But the thing about head injuries, and the thing that we have to worry about as respiratory therapists, is usually not the primary insult. It's the secondary insult or injury that results. So the primary insult or injury is of concern when the injury is really, really bad. So how bad the brain is damaged is determined by the intenseness of the blow. Primary injuries are related to the physical impact of the brain against the cranial bone. As you know, the brain is secured by or protected by the outer bony cranium or skull. But sometimes the fact that that cranium or skull is so rigid and does not expand and such can cause more damage to the brain than good when there is some trauma. The good thing about pediatric patients is not all of their cranium is bony structure yet. A lot of it is the having a brain fart is cartilage. Yes, that's the word, is cartilage. And therefore, cartilage does expand and contract, allowing for some of those secondary responses like inflammation. So primary injuries are related to the physical impact that the brain has with the cranium, and that can result in things like fractures and contusions. Secondary injuries can occur when there's a head injury, and the major secondary injury has to do with the fact that the initial injury causes ischemia. So the tissue that actually hit the cranium can start to die off, and it has less blood flow. And since it has less blood flow, it has less oxygen being delivered to that part of the brain. So you end up with hypoxia, hypotension, and because of the decrease in ventilation, you'll have hypercarbia because the CO2 will start to increase. And the other thing that is associated with the ischemia, in addition to the swelling, is hematomas, but worst case is herniation, because the only escape route that that brain matter has is down the foramen ovale. And as you know, we just talked about spinal injuries. The spinal cord runs down from through the cranium down to the thoracic cage through the foramen ovale. So the way that it exits the cranium is through the foramen ovale. Well, if you have inflammation of brain matter, and then that brain matter is trying to herniate down the foramen ovale, then you have structures that are pushing on the spinal cord, which will cause it not to work properly. So a head injury can result secondarily into a spinal cord injury. The effects of the secondary injury is to damage areas of the brain that may not have been affected by the primary insult. So yeah, you might have just hit your forehead on the steering wheel, or in a pediatrics case, the kid might have been on a jungle gym or something and fallen and hit their head on the cement. However, that injury to that part of the brain may not be the bigger concern. It could be that because of the inflammation and all the swelling, the brain matter started to herniate down through the foramen ovale, push up against the spinal cord, and now you have a secondary spinal cord injury. And as time goes along, if you don't intervene and do something as the brain is trying to heal itself because of the cranium in closing it, the entire brain may become involved. When this happens, you have a higher rate of morbidity and mortality. So the goal as a therapist is to help treat and prevent secondary insults. When we have a pediatric patient who is comatose with signs of brainstem injury that has not suffered irreversible damage but can still recover if proper treatment of intracranial pressure is initiated quickly. So if we get a patient and they're showing those signs early on, maybe through the ED when they first come in, they will do things at the bedside like a craniotomy, where they'll take a piece of the cranium, remove it, allow the brain to herniate through that open area, because we know inflammation is a part of the healing process. Inflammation is not a bad thing. It's just bad when there's nowhere for it to go. So we give it that room for it to be inflamed, because we know over time the inflammation will go down as the brain starts to heal. And then we have to assess and see what functionality the brain has left after going through that process. With the good thing about neonates and pediatric patients is that they have a high likelihood of making it through that process. A lot of kids come in with head injuries, as it was stated earlier, 500,000 hospitalizations due to head injuries. But you only end up with 3,000 to 4,000 of them. That's like less than 1%. So these kids actually make it through. So don't be surprised if you're in a pediatric ICU and you see a head injury patient, and then months later you see them walk out of the hospital as if nothing ever happened. Treatment, I mentioned about the craniotomy, but it also begins at the site of the accident. So things that we can do at the bedside are like craniotomies, but when they actually get to the patient, EMS has a big role in how well the patient may recover. The most important aspect of treating a head injury patient is to maintain and protect the airway from aspiration. As you know, if the patient were to aspirate in addition to the head injury, now you have to deal with pneumonia, and that's a secondary diagnosis that the patient may have, in addition to the primary and secondary injuries to the brain. So we may have to treat the patient by ventilating and oxygenating them simply because they aspirated due to the head trauma. You do want to intubate these patients to maintain their airway. If they are severely injured, we know that we're going to have to take over that function. The most reliable indicator, this is an MBRC exam question, the most reliable indicator of the severity of injury to a conscious patient is the Glasgow Coma Scale. You don't have to get that deep into the scale, knowing the ratings and such. Just know that the Glasgow Coma Scale is what we use to determine a patient's consciousness level. The text goes on to say the diffuse swelling of the brain is most common serious finding. I mentioned that earlier, following a severe head injury, and its treatment is the keystone to the neurologic recovery. So anytime that you have a patient that's showing signs of edema, if they're obtundant, sweating, vomiting, if they have bradycardia, they may occur rapidly or slowly, depending on the severity of the injury. Those signs and symptoms can come upon them quickly, or gradually over time, you may see these symptoms start to occur. The most severe injuries present in a deep coma immediately following the injury. So the patient comes in and they don't respond to anything, but they're still breathing and their heart is still beating, then that's considered a deep coma. There's often evidence of decorticate and decerebrate posturing, abnormal pupillary responses, and apnea. And the diagnosis of brain swelling is confirmed by CT scan, which shows a decrease in the size or even a total loss of the ventricles. So it is important to view the brain, do a brain scan via CT when you suspect that the patient has a head injury. Our goal as a therapist is to hyperventilate a patient who we suspect has a head trauma. We want to get their CO2 levels low. Think back to your mechanical ventilation course as this was covered. You want to make sure that you have low CO2s, 25 to 30 is the goal. And you want to make sure they have plenty of oxygen available, PaO2s above 100. The purpose of the hyperventilation is to cause a constriction of the cerebral vessels. As you know, the more CO2 you have available to the brain, the more vasodilation you have going on. You do not want that to happen. So we have to intervene, and because all that does is take up space, and we don't need anything taking up extra space when you have brain injuries. So you want to vasoconstrict the cerebral vessels, and in order to do that, you need low levels of CO2. And hyperoxygenation reduces the chance of further hypoxic damage. You already know that the patient is having peripheral vasoconstriction going on, cerebral vasoconstriction going on, but you don't want that to cause hypoxia. So increase the O's, but decrease the CO2s. They go on to talk about tidal volumes. With pediatric patients and head injuries, we really don't do much manipulating to the tidal volumes. We do have high rates set, but the goal is always, even with head injuries, always to have low inspiratory pressures. You always want to avoid having high inspiratory pressures. So have those pressures as low as possible, even when you have head injury patients, even more so with head injury patients. Increased intracranial pressures. That's another reason why we want to keep the tidal volumes down, because we do not want to increase the pressures in the intracranium. I said tidal volume, I'm sorry. You want to keep the pressures down, because if we have high pressures in the thoracic cavity, that will cause there to be higher pressures in the cranium as well. There are meds that we can give in relation to increase IC pressures, and furosemide mannitol is one, and phenobarbital is another. And the last thing they mention is keeping the head elevated 30 to 45 degrees. With near drowning victims, the big thing you have to consider is what type of water they were in when they drowned. For pediatric patients, it is more common to see them having drowned in fresh water, and for adults, it is more common to see that they have drowned in salt water. And the issue with the difference between salt and fresh water is that fresh water is hypotonic to the blood, which means that when you have fresh water that enters into the lungs, it's going to cross over the AC membrane and dilute the blood. And when you have all this water, fresh water get into the bloodstream, it will cause the blood cells to actually burst. But when you have drowning in salt water is hypertonic to the blood, meaning that wherever that water is located, the blood is going to want to come to it. So essentially, the blood in your bloodstream is going to cross over the AC membrane, heading over into the alveoli, and essentially flood the alveoli. So you end up with pulmonary edema when you have salt water versus fresh water. The water goes over and fills the blood vessels with more fluid, and you end up with the bursting of the red blood cells. Okay, so what do we do when we have a patient who has drowned? There's three things we need to be concerned about, and that's, did they have a cervical spine injury when they went into this water? Did they have, could they be experiencing hypothermia because of the temperature of the water, and also the aspiration portion of it? Because not all drowning ends up with flooding of the lungs with the water that you were drowned in, because you can have the larynx that could start to go into spasm because something foreign is rushing into it, and if it spasms, the epiglottis is going to cover over the trachea and nothing will get in. Now that's the initial response to the flooding of water trying to get into your airway. However, once you go unconscious and everything starts to relax, then that is when the lungs will get flooded, whether it's fresh or salt water. So it really depends on when the patient was expelled from the water, how long they've been in the water, what type of water it is, the temperature of the water. All those things are of concern to us. One of the major things with drowning is anoxia, because the brain does not receive oxygen during these drowning escapades. And even if we were to get them back, you could end up with a patient who may need to be ventilated long term. For patients that experience hypothermia, it's actually a good thing, because when the patient is submerged in water that has a very low core temperature, it is more likely that once they are submerged, you have a longer time frame to actually get their organs to start functioning properly. So essentially, it's like you kind of froze them, and because you froze them, their organs are kind of sealed in that moment in time. And once the temperature starts to come back to a normal body core temperature, that is where the window of opportunity begins, to where now you have to get those organs working back properly, so that the person can have a better chance of survival. So patients who were submerged for 40 or more minutes in water that was considered hypothermic have actually survived the submersion. But so total resuscitative efforts should continue until the core temperature has rewarmed to near normal levels. This is also the reason why when someone has been in cardiac arrest, that we may consider using hypothermia as a way to sustain them a little longer. Okay, the combination of increased intracranial pressures and diffuse lung involvement make a difficult situation for us as respiratory therapists. So if you have a patient who has is experiencing near drowning and also hit their head in the midst of it, it could cause a long road for you to toe when trying to get this patient back, because they're going to have decreased lung compliance and also increased resistance. Therefore, you're going to have to utilize ventilation techniques that will require higher pressures to compensate for the fact that their compliance is so low and there's resistance in the tubes. So the high pressures that may have to be used, even though we have other means to deliver breaths nowadays. But if you have, say you're using conventional ventilation, you're going to have high pressures, and those high pressures will in turn increase intracranial pressures. In this difficult circumstance, ventilator settings are maintained at levels adequate to provide desired oxygenation and ventilation, but low enough to avoid harmful increases in intracranial pressures. So in other words, when you have a patient that has experienced near drowning, you must be mindful of the intracranial pressure. So they're going to insert a catheter into their cranium or a bolt to monitor those pressures like you learned in hemodynamics, as well as ventilating these patients. So don't be surprised if you see a near drowning patient who also has ICP monitor in place. In the presence of increased brain pressures, the patient is treated pharmacologically and mechanically. And we've already talked about this when we dealt with head injuries. Okay, Reye syndrome is a toxic encephalopathy, so a disease process that affects the brain. And it affects children from 2 months to adolescence, but is most common from children ages 6 to 11 years old. It's unknown why Reye syndrome occurs, but most of the patients who end up with Reye's syndrome report that they had some type of viral illness prior to the signs and symptoms. Many viruses have been implicated in the etiology of Reye, so no one specific virus, but there have been many that once a patient was diagnosed with Reye's, they found that they had some type of viral infection prior to it, including parainfluenza, Epstein-Barr, Coxsackie, mumps, rubella, adenovirus, herpes simplex, polio, influenza A and B, varicella. So as you see, there's a short list that your textbook gives you, but all of those viruses and others could have been what the patient had initially, and then they end up with symptoms of Reye. Influenza A and B and varicella are most frequently associated with the onset of Reye syndrome. There may be an association between ingestion of aspirin, and this is what the MBRC will throw at you to see if you can catch this correlation. But association between the ingestion of aspirin during the initial stages of the illness and the occurrence of Reye syndrome. And that is why the American Academy of Pediatrics recommends that you don't give aspirin to children with varicella or any suspected type of flu or influenza. So the two most affected organ systems in rays is the brain and the liver. The disease apparently affects the mitochondria of the cells, and when they go in and take some of the tissue and do an they use an electron microscope to look at the tissues. It reveals large, swollen mitochondria in the brain and the liver. The results in the liver is a net reduction in the enzymes that converts ammonia to urea, leading to hyperammonemia. So in other words, you have increased ammonia in the blood. The liver dysfunction is also manifest by the presence of elevated SGOT, SGPT, and LDH levels in the blood. The diagnosis of Ray's syndrome is often accomplished by performing a percutaneous liver biopsy. So they have to be able to look at the tissues in the histology department under an electron microscope. The biopsy will reveal swelling of the hepatocytes with minimal inflammatory response, and then the prothrombin levels will be diminished because you don't have the inflammation. And a majority of the patients also have a drop in blood sugar levels. So that's another sign or symptom that the patients will present with. So the blood sugar levels will be below 50 milligrams per deciliter with reduced insulin levels. The child initially will present with symptoms of an upper respiratory viral infection or even the chickenpox. During the apparent recovery stage of the viral infection, the child then develops a recurring vomiting and worsening central nervous system function. Progression of disease is variable, so it can, as it progresses, it doesn't always present the same way, which is why they mention that it's variable, ranging from a few hours to a few days. Changes in sensorium deteriorate from lethargy in the early stages to coma. The patients may also become hyperexcited with arms and legs thrown about. And as the brain damage worsens, the patient enters a stage of decorticate posturing. And with decorticate posturing, that's when you have flexing of the upper extremities and extending of the lower extremities. The patient then begins more ominous signs, basically signs saying that they're heading in the wrong direction, such as decerebrate posturing, where both the upper and lower extremities are extended and they look very rigid. The muscles become flaccid. They have periods of apnea. The circulatory system starts to collapse, and essentially death will occur. So how do we treat Ray's syndrome? We want to slow down the progression of the disease as much as possible. That is the goal. But successful treatment of Ray's syndrome requires early detection. If we don't detect it early enough and be able to give that aggressive approach to the treatment, then we may not be able to keep the disease from progressing as was stated in the previous section. The progression of the disease and appropriate treatment are determined by the stage that the disease is in once the patient is presented. Stage 1 of the disease requires supportive care, correction of hypoglycemia, and any changes in the acid-base status. We need to address those. And also control the edema to the cerebral cortex. The patient in stage 2 requires more aggressive monitoring. Special attention for these patients are focused on blood glucose levels, coagulation studies, as mentioned earlier with the prothrombin levels, blood chemistries, and body core temperature. The patient should be made as comfortable as possible, and the respiratory procedures that should be performed are things like CPT and suctioning, And the reason why we need to stay on that is because we don't want the patient to um, aspirate, and we want them to be as comfortable as possible. So we need to get them sedation on board in addition to making sure that we clean out their pulmonary toiletry. Stages 3 through 5 are treated aggressively in the ICU. Patients electively intubated. We proceed by the administration of thiopental and either succinylcholine or pancuronium. The patient is maintained in a pharmacological paralysis to allow hyperventilation. And the same reasons we hyperventilated patients with head injuries, we're going to do the same for this patient. The patient is maintained. The brain swelling is treated as described previously under head injuries. Additional respiratory care includes appropriate pulmonary toiletry, which was mentioned earlier, to avoid complications, maintenance of analgesics. Pain relief is important because pain and anxiety may increase the intracranial pressures. We also want to monitor the intracranial pressures, as mentioned earlier. We want the pressures less than 20. We also may have to do dialysis or blood transfusions to reduce the amount of ammonia levels in the blood. Mortality rates have dropped for Ray's syndrome due to the fact that we can diagnose it early and aggressively treat it. Recovery is rapid and without long-term effects in the presence of early diagnosis and treatment. The child may awaken disoriented and frightened with no recollection of the hospitalization. So you have to be mindful of that as a therapist. If you're in the room and the patient starts to come to out of this whole ordeal, you need to take the necessary steps to lessen the fear and confusion that the patient may present with when this happens. With infectious pulmonary diseases, pneumonia is the most common serious infection that will occur in newborns. As a cause of death in neonates, it is only second to hyaline membrane disease, which is just another form of ARDS for infants. Pneumonia may be acquired while the infant is still in utero, and infection of the amniotic fluid leading to congenital pneumonias is additionally a cause of premature labor. So if the baby, the fetus gets an infection in utero, when they are delivered, of course, we will see the effects of that in their lungs, and their lungs will have a restrictive component since pneumonia is a restrictive disease. There are 3 factors that factor into if the baby gets an infection in utero. Prolonged rupture of the amniotic membranes. So we don't want the baby in the amniotic sac when it is time to deliver them more than 24 hours. Prolonged labor, even in the presence of an intact membrane, they can still get an infection. Excessive obstetrical manipulation, so they don't want to manipulate the baby too much when they do exams and such. So excessive manipulation during the obstetrical exams are contraindicated. The most common causative organism of perinatal infections are enteric organisms like E. coli and group B strep. And group B strep is often abbreviated GBS. Postnatal pneumonia is most often caused by contamination of the neonate's airway by infected equipment such as humidifier reservoirs, poor hand washing of the healthcare professional or the parents or family members that come visit baby, contaminated incubators, or other equipment that may be used on or near the neonate. The most common organisms causing postnatal pneumonias are Staph aureus and Staph epidermidis. Other organisms causing pneumonia are Klebsiella, type B influenza, Pseudomonas aeruginosa, and Candida albicans, which is nothing but yeast. Thrush is how it's presented in the infant. Non-bacterial organisms that cause pneumonia are acquired by contact with an infected birth canal or by some type of nosocomial infection given to the baby from healthcare professionals or family members. Those organisms acquired from the birth canal include, of course, herpes simplex, cytomegalovirus, CMV, chlamydia, trichomitis, and ureolecticum. Nosocomial infections often include RSV, most commonly seen RSV, rhinovirus, and enterovirus. Okay, how do we diagnose that a patient has pneumonia? The diagnosis of neonatal pneumonia is inexact. So we first have to get a history, physical exam, chest x-ray, and lab data, and all of those things need to be pointing us towards pneumonia. Symptoms of pneumonia often occur at birth. Usually within 48 hours, we'll start to see those stiff lungs. The patient will be tachypnic. They'll be showing signs of respiratory distress. Sometimes they're even flaccid, pale, cyanotic. The amniotic fluid may be foul smelling, indicating the presence of an infection. Labs may show that the WBCs are depressed below 5,000, or they could be elevated above 1,500. Elevation of the patient's temperature is possible. And with premature infants that have pneumonia, they may actually be hypothermic because it's going to affect their ability to keep their body core temperature normal. They already have complications with that since they're premature. The chest x-ray unilaterally or bilaterally will show streaky densities. That is basically a term that's used in infant chest x-rays to show atelectasis. Signs of post-delivery pneumonia include an increasing tachycardia, poor feeding, possible aspiration of feedings, and lethargy. Any infant who shows signs of pneumonia or who is at risk for developing pneumonia is started immediately on a broad spectrum antibiotic to combat any potential infections. And then we treat any clinical symptoms that may appear and also get blood gas values. Of course, we use cap gases on infants, and we closely monitor and treat them aggressively. Okay, with bronchiolitis, which is another infectious lung disease, it is a virus that leads to inflammation, swelling, and constriction in the bronchioles. It has the highest mortality and morbidity among infants less than 6 months old and those suffering from congenital cardiac defects, as well as BPD, bronchopulmonary dysplasia, which we'll talk about later, cystic fibrosis, and asthma. The most common causative organisms are RSV, causing approximately 75% of all cases, and the parainfluenza virus, as well as Mycoplasma pneumoniae, rhinovirus, and adenovirus. RSV infection is highly contagious and requires extreme care in hand washing and other precautions to prevent nosocomial outbreaks in the hospital. So if you are working with a baby with bronchiolitis, you can essentially pass that on to the other patients if you are not doing proper hand washing and utilizing PPE properly. So how we diagnose patients with bronchiolitis? Bronchiolitis begins in the upper airway, and therefore the patients will present with a runny nose, cough, fever that has lasted 2 to 3 days. With the onset of bronchial involvement, the cough is going to start to worsen, and the patient of less than 3 years of age will begin to show signs of small airway obstruction and congestion. These signs include intercostal retractions, wheezing, rhonchi, crackles, and hyperinflation. If you have a child that's older than 3 years, it is seldom that they will be affected to the same degree. So they don't show with all of those signs of distress. Upon presentation of the symptoms, an RSV culture is obtained from the nasal pharynx. And it is important to rule out other processes such as cystic fibrosis, pertussis, when they're doing the diagnostic workup. It has been suggested that infants with repeated bouts of bronchiolitis be considered to be asthmatic, because it could be that their reactive airway is causing the inflammation of their bronchioles. The way we treat bronchiolitis, if the patient is less than 4 months old, they may need to be hospitalized so we can control their fluid intake, and also to monitor them for periods of apnea. In the patients who require hospitalization, the level of distress and blood gas values will determine how we move forward with their treatment. Patients with severe distress and apnea and worsening blood gas values are treated with ribavirin. It's very important to remember ribavirin is what we give to bronchiolitis patients that are in severe distress. And then while not recommended as a treatment for all bronchiolitis patients, ribavirin seems to benefit most of the patients at high risk. And what we consider high risk are patients with a history of an underlying disease such as hypoxia, prematurity, young age, apnea, pulmonary consolidation, that we've determined by looking at a chest x-ray. And as you know, ribavirin is given via a SPAG nebulizer. SPAG is small particle aerosol generator. Treatment is done for 12 to 18 hours for at least 3 days, but no more than 7. If a patient is on a vent, you can safely give ribavirin through the ventilator. However, it does not appear to affect the immediate outcome in patients that are having to be ventilated. It is important that if you're going to administer ribavirin, that you're very careful when doing so, because you want to avoid inhaling the drug yourself. And we'll talk more about that when we get to pharmacology section. Sympathomimetic drugs and theophylline may be used to help reduce the associated bronchospasms that go along with bronchiolitis and improve ventilation until the infection clears up. You may have to put the baby on a vent when the blood gases show impending ventilatory failure, or in the presence of frequent and severe apnea. So they're having periods of apnea, and they start to have more and more and much longer time frames to their periods of apnea, then of course you need to put them on a vent. If a patient has bronchiolitis and they're having to be ventilated, they have to receive adequate lavaging and suctioning to remove excess secretions because, as you know, that's where the microorganisms collect, and we want to get that up and out of the body. Of course, you want to avoid barotrauma. Anytime you put a patient on a vent, you want to avoid barotrauma. So we use low rates and low pressures as tolerated, of course. If we need to increase the pressures for these babies, it is not uncommon, because over time of being on the ventilator, they could end up getting stiff lungs. And you know, the stiffer the lungs, the more pressure it takes to ventilate. And the next sentence talks about accepting higher than normal CO2 levels and lower than normal pHs with these babies. However, you don't want to let the CO2 go too high, and therefore in those situations you may have to increase the pressure slightly. Other things that we can do to treat bronchiolitis is to give alpha interferon, immunoglobulin A, or we may give both. And it states that they are still in experimental stages. However, that is the treatment of choice at this time. The last paragraph talks about the fact that there is no vaccine for RSV, even though they're working on it. However, if the patient presents with bronchiolitis, we will be treating them for the virus, respiratory syncytial virus. Outcomes, long-term effects of the RSV infection that's causing the bronchiolitis is difficult to assess, because the infection is universal. In the first few years of life, it is very common to see the RSV infection, and no uninfected control group exists. So it's kind of hard to do a study if you don't have a control group, but everyone in the group seems to have the infection, so they haven't yet been able to get a vaccine for that very reason. But one proposed study concluded that RSV bronchiolitis in the first year of life is an important risk factor for the development of asthma during subsequent years. So they are studying it now. They just don't have enough results yet to give a clear indication, not clear indication, but a clear vaccine that will help combat this, because lots of babies come in with RSV and lots of pediatric patients come in with bronchiolitis simply because of the RSV virus. Okay, epiglottis is a acute inflammatory disease, and it deals with the upper airway, and it doesn't just affect the epiglottis, but it affects the surrounding airy epiglottic folds and arytenoid cartilages, and that's very important. The most common cause of epiglottitis is the flu. And epiglottitis is a life-threatening disease. Very important for you to understand. Epiglottitis is life-threatening, and once you get the patients in, it is important to diagnose them and treat them immediately. Mortality from epiglottis is due to the blockage of the trachea by swollen, inflamed tissues, leading to asphyxiation. The rapid onset of tracheal blockage makes intubation extremely difficult. For these babies, intubation may not be the treatment of choice. You may have to go straight to a tracheostomy. So if it is difficult to intubate the baby, anoxic brain damage may be more pronounced. So how do we diagnose them? The patient with epiglottitis may present with symptoms similar to croup. And we haven't talked about croup yet, but croup and epiglottitis kind of present the same way, but there are some telltale signs to let you know which one you have present. when you are doing your diagnostic workup. So diagnostic differences for croup and epiglottitis are presented in your textbook, but diagnosis of epiglottitis is based on history, clinical signs, and an x-ray. That's very important. The inflammation of the epiglottis is due to a bacteria. So it has a rapid onset and it's usually less than 10 hours. The patient will complain of severe sore throat and will be febrile. Swallowing will be difficult because of the swelling, and it'll also be painful. Patient often leans forward and drools. Telltale sign of epiglottitis. Patient is leaning forward and drooling because it hurts to swallow. Their voice may be muffled, and they may have soft inspiratory stridor. So the stridor will be present, but it may seem far off. The way that we verify that the patient has epiglottitis is we take a lateral neck x-ray. Very, very important that you understand. In order to clearly diagnose that the patient has epiglottitis, you do a lateral neck x-ray. And in this x-ray, it will show that you will be able to visibly see the epiglottis at the base of the tongue, and it will be extremely large and balloon-shaped. Because the epiglottis is clearly visible, we call this the thumb sign. So when you look at the lateral neck x-ray, it will show the thumb side. And the vallecula, of course, will be obliterated. You won't be able to see that. Direct visualization of the epiglottis should never be attempted, as this could irritate the inflamed tissues and cause complete airway obstruction. From the moment of arrival to the hospital, all patients with suspected epiglottitis must be accompanied by personnel with the skill and equipment necessary to intubate the trachea if needed. So these babies, you do not wait and see how things are going to go. You want to treat them immediately. It's urgent. This is a matter of life and death. The first priority, therefore, is immediate establishment of an airway, either by intubation of the trachea until the swelling subsides, or a tracheostomy. Many centers routinely use nasotracheal intubation as the airway of choice in epiglottitis. So if you're going to intubate them, you have to do it nasotracheally. If you're not going to intubate them, then go ahead and do a tracheostomy. They go on to talk about making sure you have a trained person. That kind of goes without saying. Once intubated, every precaution is taken to prevent accidental extubation. These babies, you do not want that tube to come out. So we will very commonly sedate these babies and give them a sedative that does not depress their respiratory drive. That's important. So we'll maybe give them some morphine, fentanyl, midazolam, or lorazepam. And the patient's limbs should be restrained to avoid self-extubation. So that's why we got to keep them sedated, because just tying down a baby can be a bit overwhelming. Meticulous care is taken of the artificial airway to prevent further complications. Suctioning is only done as needed. Remember, there's nothing wrong with their lungs. It's their upper airway. if you do suction them, make sure you hyperoxygenate, not hyperventilate, hyperoxygenate them with 100% oxygen. CPT may be indicated if there is a presence of increased secretions to prevent atelectasis and infection. You may need to also heat and humidify the gas, and then closely monitor the patient. Arterial oxygen levels should be continuously monitored by transcutaneous monitor or a pulse ox. That way we can make sure that not only are we ventilating them properly, we are oxygenating them properly. Oxygen is given as needed to maintain patient in a normoxic state. So we want the O2 levels to be normal. And we also want to monitor the heart. Okay, once we have intubated the baby, treated them with antibiotics, like ampicillin or some type of third generation cephalosporin, then inflammation of the epiglottic region should go down very quickly within about 24 to 36 hours. Once the inflammation has gone down, we can go ahead and extubate them because the danger for the airway occlusion has subsided because the inflammation has subsided. So if we paralyze the baby, if we give a paralytic, you know that we have to keep them on a ventilator. But once we back off of all these things, once the inflammation has gone down, we can consider taking them off. While they are on a paralytic, we need to make sure that we maintain low pressures, low rates, and FiO2 is only given as needed. Okay, croup. Croup is also called laryngotracheal bronchitis, or LTB. The NBRC likes to make sure that you know the difference between the names, because they already know just with the name croup, it kind of tells you what's going on with the baby, as you'll see here in a moment. But laryngotracheal bronchitis is the term that they will use instead of croup. There are three primary disorders that fall in the category of croup. The most common one that you will see at the bedside is laryngotracheitis, so inflammation of the larynx and the trachea. Spasmodic croup and laryngotracheal bronchitis are less common manifestations seen in pediatric populations, but as the name suggests, spasmodic croup is nothing but a spasm of the upper airway. And then with laryngotracheal bronchitis, it's the bronchioles, the larynx, and the trachea are all inflamed. So how do we diagnose that the patient has croup? We have to get a sputum sample, of course, and we can do that. We can get a sample of the upper airway by swabbing the mouth or actually getting the patient to cough up sputum. But we're looking for the viral organism. And parainfluenza virus accounts for about 75% of all cases of croup. RSV, influenza, Mycoplasma pneumoniae, causes about the other 25%. Regardless of the viral component, the onset of the virus usually starts with the common cold. The patient will complain of a runny nose, cough, fever, upper airway congestion. The onset of the symptoms are much slower with croup. Very important to remember. The onset is slower than, slower than epiglottitis. The onset of croup symptoms is much slower than what you see with epiglottitis. usually about 3 to 4 days, versus epiglottitis was 24 hours. The patient typically wakes in the night with a tight, barky cough. The patient has upper airway stridor on inspiration and expiration, and is usually in a degree of distress relative to the amount of airway obstruction. So the more obstruction, the more distress the patient is in. For these patients, if we're suspecting that they have croup because they have reported having a runny nose, cough, and fever for the past 3 or 4 days, then we are going to take an AP neck x-ray. So they're going to be in the same position as they would a chest x-ray, but they're going to shoot the rays through the neck. When they do that, if the patient is positive for croup, then there will be a narrowing of the airway at the level of the larynx. The trachea on these patients has been described as an hourglass, a pencil, or steeple. The steeple sign is the most common term used by the NBRC. So basically, you will see the air, the location of the trachea and the larynx coming down from the skull, and at some point it will come to a pinpoint looking like a steeple. The spasmodic croup is an apparent allergic response that results in a sudden onset, usually at night, of a barking cough, shortness of breath, and stridor. The symptoms last for several hours, but then they subside. The distinguishing factor between spasmodic croup and the inflammation of the larynx and the trachea, or the larynx, trachea, and bronchioles, is history. So the patient with spasmodic croup is typically a healthy kid with no signs of upper respiratory infection. And then there is often a frequent familial history of spasmodic croup and asthma. So other kids in the family or the parent, one or both of the parents may have had the same symptoms growing up. With laryngotracheal bronchitis, you have a bacterial superinfection of all of those areas, the larynx and the trachea, as the name suggests. This category of croup involves not only the upper airway, but progresses down to the bronchioles as well. So how do we treat croup? In mild cases, you just monitor them. You can even treat them at home. We send these kids home with humidifiers. Tell parents to keep them adequately hydrated and just observe them. However, any sign of distress, such as retractions, increased respiratory rate, nasal flaring, are indications for the need of medical intervention. So it is very important that the parents understand how to care for a kid with croup at home. Because of its viral origin, common croup is treated by support and administration of drugs to reduce the subglottic swelling until the infection subsides. We give racemic epi to these patients, and it causes a local vasoconstriction of the swollen tissues and reduces the edema. If the stridor continues after the treatment, the patient will then be hospitalized and medicated. Medication nebulizer treatments are continued as needed every 1 to 2 hours to relieve the airway occlusions. So if we have a kid that comes in with croup, we're going to start them off with racemic epi. If all is well after we give the racemic epi and we see a change in their status, then we can send them home and have the parents administer the medication. If it does not subside, then we will keep them and monitor them closely as we give the medication. Steroids are often given. Decadron is the popular drug of choice due to its long half-life, 36 to 72 hours, and because it is much more potent than hydrocortisone. Patients with severe obstruction of the airway may benefit from use of oxygen, helium gas mixture. So that is sometimes chosen for these patients. If they have problems oxygenating, we'll do an O2 helium gas mix. And we also may put them in a cool mist tent to help reduce the swelling as we are administering the oxygen. Severe manifestations of croup, such as labored breathing, decreased breath sounds, retractions, worsening blood gases, may require intubation and the institution of mechanical ventilation. We can use glucocorticoid therapy for the treatment of croup, and we can use budesonide. With aspiration syndromes, as you know, pediatric patients like to stick things in their mouth. So when they do, this further complicates the narrowness of their airway. They're born with narrow airways to begin with. You put something in that airway, it's going to make it even harder for them to breathe. Even the smallest objects cause a potential airway obstruction. Aspiration of gastric contents is also a concern for the newborn because of reflux. So if you have an infant that presents with aspiration, you also have to consider that they may have aspirated their gastric contents, which could be caustic to the airway. Pathologic results of aspiration include air trapping, tissue damage, especially with gastric contents or sharp objects that might have been ingested, and hydrocarbon aspiration, depending on what substance it was that they ingested. Air trapping is the result of a ball valve effect. That's important to know. Basically, once the object is aspirated and advances deeper into the airway, as the airway dilates, and then the object becomes further trapped during exhalation, the airway collapses back to its original size around the object. So as it dilates, the object moves down further, and as they exhale, it squeezes around the ball or object. The result is the trapping of air behind the object, which leads to hyperexpansion of the lungs, so air trapping. You also have reduced ventilation and possible pneumothorax because of the barotrauma. Aspiration of hydrocarbons such as gas, oils, turpentine, kerosene can all cause damage to the epithelial lining of the lungs, called chemical bronchitis. So you have inflammation because the chemical causes the inflammation. Absorption of these toxic liquids in the blood leads to central nervous system disorders and toxic cardiomyopathies, and also hepatosplenomegaly. So the liver and the spleen may get enlarged due to inflammation because of the chemical substance that has been presented. Chemical bronchitis leads to inflammation, edema, atelectasis, mucosal necrosis, and, if aspirated deeply, the formation of haline membranes, which is basically just fibrotic alveoli, so you have stiffening of the lungs. So the way we diagnose it, of course, is to get a history of the fact that the patient aspirated something, a foreign body usually. The patient has a sudden onset of a dry, hacking cough. Patient may have been observed eating the object before the onset of symptoms. If the object is inhaled deeply into the tracheobronchial tree, the coughing may subside somewhat. Chest X-ray examination may show air trapping distal to the obstruction during expiration. hydrocarbon aspiration is probable when the symptomatic patient is found near an open container of some type of liquid that contains hydrocarbons. And they also check the patient's breath for strong odors of the liquid. Treatment of an aspirated foreign body involves measuring the object so that it can be removed. Sometimes, most typically what they do is a bronch, and they go in and get the object out. Chest physiotherapy may help dislodge the object if it's small enough, and severe cases may require the use of a bronchoscope. Treatment of hydrocarbon aspiration, however, is nonspecific and consists mainly of support. We can't just go in and get the chemicals out, in other words. However, if the substance has been swallowed, vomiting may not be induced. You do not want these babies to vomit. That's when you give them the Ipecac syrup to keep the substance, to basically dilute the substance and keep them from vomiting. As symptoms dictate, the patient is often given oxygen and bronchodilators, or they may have to be intubated to protect their airway and mechanically ventilated if they are having signs of respiratory failure. Okay, since we just got through talking about aspiration, I'm going to go a little more into that concept by talking about foreign body airway obstructions. With aspiration syndromes, it doesn't necessarily mean that a foreign object is actually in the airway, but specifically if there is something in the airway, the most common patients that you see that with are 6 months to 3 years of age. The child may present with a cough, but will not be febrile. So afebrile with a cough. Usually they'll have a history where they were seen chewing on something, as was stated back under aspiration syndrome, or the family member may have actually seen them put something in their mouth. But sometimes they come in and they just have a cough and no other sign or symptom to lead you to think that it could be some type of infection. And of course, they won't have a fever, and therefore that would hopefully lead the healthcare professionals to decide to get a chest x-ray. The only thing about chest x-rays is that most aspirated objects are radiolucent and cannot be seen on a chest x-ray. What they do in addition to the chest x-ray is do inspiratory and expiratory films. And that will actually allow them to see if there is some air trapping going on. The way that we treat foreign body airway obstructions is to perform emergency procedure if the child is actively choking or struggling, not struggling. I see there's a typo there. And they may use a rigid bronchoscopy to go in to expel the object. Of course, you want to give the patient O2 therapy and postural drainage and percussion therapy, especially if the object can possibly be broken up into pieces. You want to do CPT to get out any residual parts of the object that may be left in the lungs after the bronch. Okay, now back to the textbook. Inhalation of noxic gases are next, and we're going to talk about smoke inhalation as well as chlorine inhalation. Now, smoke inhalation is a broad category that covers the noxic gases that can be inhaled via smoke. The thing is about fires is that most deaths where patients have been in a fire actually don't occur from the fumes, don't occur from the fire itself. They occur from inhaling the fumes from the gases that are burning during the fire. So, you have furniture and other types of material in the building that, as they are burning, they give off a fume. And when you inhale those fumes, that is what people usually die from. And then if they aren't expelled from that area, eventually, they will receive some burns to their body. But what literally made their organs stop working would be the fumes that they are inhaling. So the fumes that they list in your text are carbon monoxide, sulfur dioxide, hydrochloric acid, phosphogene, and hydrocyanic acid. And the two most common ones that we have when our patients come in, that our patients will have, is carbon monoxide and hydrocyanic acid. And the reason being is because both of those gases will absorb into the bloodstream. We already know about carbon monoxide and how the hemoglobin has a high affinity for it. Well, hydrocyanic acid, basically what happens to it is it breaks down into cyanide. And as you know, cyanide is a poison, but the issue with cyanide is that it prevents the uptake of oxygen from the blood by the tissues and leads to rapid death. So hydrocyanic acid is really bad, and so is carbon monoxide. But with carbon monoxide, it binds to the carrying sites on the hemoglobin, and that's why patients who breathe in carbon monoxide will have problems oxygenating, because the red blood cell itself doesn't have the ability to carry the oxygen because those sites are taken up by carbon monoxide. So what you end up with long term is hypoxia to the tissues and eventual death. Now, because you are inhaling gases and possibly even particles, maybe getting down into your lungs when you are dealing with smoke inhalation, the side effects that go along with that is that you might damage the epithelial lining of the tracheobronchial tree. And of course, when that happens, that will result in spasms of the airway. Obstruction of the airway, edema, necrosis, sloughing of necrotic epithelium, and bronchial spasm. Airway damage may also occur from thermal injury. The thing about thermal injuries, though, it's usually just confined to the upper airway. So thermal injuries happen because of the heat that you are experiencing when you're in a room where there is fire, but it doesn't make it all the way down to the alveoli. Now, how do we diagnose that a patient has inhaled some noxious gas? First, we got to have a history, of course, of being involved in a fire or being suspected that they have suffered smoke inhalation from being in an environment where there was a fire. And the patient with significant carbon monoxide poisoning may complain of headache, nausea, vomiting, and of course, what you're going to do is check their carboxyhemoglobin levels. And if their levels are between 20 and 30%, we will typically see those signs and symptoms with the headache, nausea, and vomiting. As the carboxyhemoglobin increases, the patient may lose consciousness, as your book says, losing sensorium, and become comatose. Now, the diagnosis is made by actually analyzing the carbon monoxide level by doing a blood gas and sending that blood through a co-oximeter. Signs and symptoms of airway damage may be present immediately or may be delayed for hours. The patient shows signs of ever increasing respiratory distress with tachypnea, retraction, cyanosis. As the airway obstruction increases, then of course aeration is going to decrease. Their ability to send oxygen to their tissues is going to decrease. Widespread atelectasis is going to occur, and the patient's status will start to quickly diminish. So if you have a patient that has been suspected of being in an environment where they have inhaled some smoke, then the treatment is to give them 100% oxygen. Same thing as with an adult. Even if it's a pediatric patient, you're still going to give them that 100% oxygen. And the textbook talks about hyperbaric oxygen administration, and the clinical environment has not caught up to that as of yet. This is not a common therapy given to patients with smoke inhalation, but it is something that could be considered under special circumstances. But what we do, however, use as therapy is to tightly seal, as best we can, the non-rebreather. So we put them on a non-rebreather. We make sure that there's a tight seal on their face with the mask. And in addition to the non-rebreather mask, we also have a cannula. And as you know, with pediatric patients, especially infants or small pediatric patients with small nares, the introduction of high flow through a nasal cannula is just like giving them positive pressure, but we're not ventilating. So it's essentially creating some PEEP. So we can deliver the pressure, deliver the FiO2 under pressure by utilizing a tight seal on the non-rebreather and adding in the nasal cannula. That'll help to increase the flow. Hypoxia that results from carbon monoxide poisoning often affects the heart. So we have to monitor their cardiovascular status, or their hemodynamic status rather. So we need to put them on an ECG monitor at least. Now, pulmonary edema, as stated earlier, is a secondary response to having some noxious gas and possibly something caustic go down your airway. So it is frequent to find that patients that are suffering from carbon monoxide poisoning and smoke inhalation also will have pulmonary edema. Because of this, it is very imperative that you assess them frequently, listening to their breath sounds, monitoring their respiratory status. Victims of smoke inhalation are at risk for developing RDS, respiratory distress syndrome, because of the tissue being wasted away. They could get necrotic, and the tissues could thicken because of the inflammation. All of that is going to cause the patient to present as a respiratory distress syndrome patient would, with the thickened tissues. This requires that you monitor the patient closely, another reason why you need to monitor the patient closely, and also to be prepared to intervene if necessary. Patients without obvious immediate airway damage are monitored closely for signs of worsening respiratory status, because you just never know when that is going to occur. When respiratory failure is apparent, the patient is intubated, mechanically ventilated, so that we can maintain their oxygenation and ventilation status. Now, medication-wise, we're going to give them an antibiotic to combat the lung infection that could occur. simply because the tissue has been damaged by the anoxic gas. Meticulous attention to proper aseptic technique is important because their immune systems will be on overdrive and therefore may not be able to help if another infection is presented. We also want to minimize the likelihood that the patient will get a nosocomial infection like pneumonia. Because of that, we want to make sure that we hydrate them thoroughly and that we are checking their electrolytes, because their electrolytes can be off due to the burns. As I stated earlier, they might not have any burns to their airway. However, if they were in the area where the noxious gas was, if they go unconscious, they could essentially get burned. And the end result of having a skin burn is to have inflammation to that area. You lose a lot of water because of the skin burns. A bronch may be needed to remove any debris from the epithelial lining, because this may clog up the airway, so that those cells are going to be sloughing off of the tube of the airway, and it could essentially block it and cause problems ventilating. Of course, you want to give bronchodilators for any type of spasms, and that'll help to maintain the patency of the airways. And we already talked about the fact that you might need to mechanically ventilate them, especially if they're comatose, because you need to secure their airway and administer oxygen. And when you need to put them, if you find that the patient needs to be put on a ventilator, then you want to use the lowest levels of oxygen and ventilate them as least amount as possible as needed. The reason why this is important is because we don't want to cause any type of barotrauma or air trapping in these patients. So the least amount of pressure possible is our goal with these patients. In addition, hypocarbia may be avoided because of the left shift of the oxyhemoglobin dissociation curve. You remember that? In the presence of alkalosis. Now, with chlorine inhalation, chlorine is greenish yellow. It is extremely irritating to the mucous membranes and the skin. And in pediatric patients, inhalation is commonly the result of accidents at a swimming pool, where the chlorine is used to disinfect the water. Chlorine is also found in a variety of household cleaning agents. So it could be that the toddler got under the kitchen sink and put some pellet of some sort in their mouth, and now they have chlorine inhalation. Or maybe they sniffed it, because to ingest it is one thing. We're talking foreign body airway obstruction with ingesting. But to inhale it, maybe they took a big whiff out of the bag and causing problems with their airway. So the injury to the respiratory tract following chlorine inhalation follows 4 phases. Phase 1 starts from the minute it happens to within 6 hours following the exposure. Choking, coughing, diminished following removal from the site. So all those signs and symptoms start to get less and less because you have removed them from the area where the particles are in the air. Minimal wheezing and slight oropharyngeal redness may be present if you are in phase 1. Phase 2 starts to occur between 6 hours to 8 days after the exposure. And the pharyngeal and pulmonary edema is the big thing with phase 2. So lots of inflammation. They could even have plugging of the bronchi with mucus. It's because your body is trying to protect itself from the initial exposure. And inflammation, as you know, is the way that the body heals itself. So atelectasis develops, as does significant respiratory distress, from the combination of upper airway edema and lower airway blockage from sloughing epithelium and tissue debris. Treatment at this point is mainly supportive, with intubation and tracheostomy often necessary. So it depends on the patient whether you need to ventilate and oxygenate them or not. Large tubes are preferable to assist in the aspiration of airway debris. You need the largest tube possible because you're going to be suctioning out some very nasty brown purulent secretions just from inhaling chlorine. Mechanical ventilation is started with signs of impending respiratory failure. High levels of oxygen may be needed to treat the hypoxemia. The use of bronchodilators helps reduce any bronchospasm that may be present. Now with phase 3, this happens anywhere between weeks 1 to 4 with gradual improvement in pulmonary function. Phase 4 occurs after the 4th week with further improvement in airway function and in blood gas status. Okay, now let's go on to sudden infant death syndrome, which is SIDS. Sudden infant death syndrome, it is just that, a syndrome where the infant suddenly dies. And although they have lots of studies out there, they really don't know why it happens. So they just have implemented some things to kind of help decrease the number of deaths, but it just happens. So the diagnosis of SIDS is not made until an autopsy is performed. A previously healthy infant who dies suddenly and unexpectedly during sleep, and an autopsy shows no apparent reason for the death, that's when they're diagnosed with SIDS. Okay, so the initiative was started way back in '92, the Back to Sleep program. While the exact relationship between the prone position and SIDS has not been determined, there are 4 factors that have been identified, which elevate the risk of SIDS in a prone position. So when you put the patient in the prone position, the concern is that the natural fibers of the mattress could cause some complication with breathing. Swaddling is another thing. Sometimes you could swaddle them too tightly and therefore not give them the ability to take breaths. Recent illness, if they have recently had some type of virus or bacterial infection, they found that there's a correlation there that the patient may actually die. But there are several other babies that will have some type of virus or bacteria and they don't die. Also, the use of heating in the bedroom. Sometimes the babies are overcome by the temperature and it could cause them to stop breathing. The reduction in the number of infants sleeping prone was seen as a major contributing factor in SIDS decline rate in Tasmania, which is where the study was done. Okay, so recent risk factors associated with SIDS have been extensively studied. Traditional risk factors are listed here: Black race, low birth weight, prematurity, 5-minute APGAR scores less than 7, male gender, those wimpy males, low maternal age, educational level. How does that relate? I don't know, but they have it listed here. Multiple births, maternal smoking are all risk factors that are associated with patients who die of SIDS. When examined statistically, the only risk factor independently associated with SIDS was maternal smoking. The link between maternal smoking, passive smoke exposure, and SIDS have been corroborated in other studies. Okay, there's several other things that play a role in SIDS, such as increased levels of interleukin 6 in the cerebral spinal fluid, surfactant abnormalities, anaphylaxis, variability in organ weights, gastroesophageal reflux, abnormal pulmonary inflammatory response, maternal cocaine use, and basement membrane thickening of the vocal cords. They state that it is more likely to have patients die of SIDS during the winter at night, and the most common ages are 1 to 3 months of age. And even with the knowledge of the risk factors, it remains impossible to identify those infants who will actually die of SIDS. The incidence of SIDS remains at approximately 2 out of every 1,000 births, which is really not a really big number, actually, and continues to frustrate attempts to solve its cause. Most common event in all SIDS death is quiet cessation of breathing during sleep. That's the scary part. They don't struggle or anything, they just stop breathing. It is apparent that SIDS is a complex, multifactorial disorder that at the present time has no cure. For the last part of this lecture, we are going to revisit some of the pediatric conditions and diseases that the MBRC commonly will have on the exam. RSV, we've already covered, but some things that you might want to remember is that it is commonly caused by bronchiolitis and pneumonia. Commonly occurs during the winter months, December to March, and most often seen in children 3 months to 3 years of age. That's very important. The way that the patient will present initially, they will start off having a low-grade fever. They may have a cough, nasal discharge, in other words, runny nose, dyspnea, and chest retractions. So that could be substernal, subclavicular, intercostal retractions, any retractions on the chest area. If lower respiratory tract is involved, they will have some wheezing and rhonchi, and tachypnea may be present. The way that we diagnose for RSV is to perform a nasal washing to test for the virus. And if we find that the patient has RSV, the treatment of choice for that condition is to give ribavirin via SPAG. Now, cystic fibrosis we covered in our disease course, but some important things to mention here for pediatric patients, which are the only ones that really have cystic fibrosis. Every now and then you may have an older adult with cystic fibrosis since they are living much longer than they have in the past. But the MBRC may not use the disease cystic fibrosis. They may call it mucoviscidosis. In other words, osis is abnormal condition, muco is mucus, and viscid is thick. So abnormal condition of thick mucus, which is what describes cystic fibrosis. You need to make sure you understand that it is an inherited genetic disorder, and it affects the exocrine glands. And the exocrine glands not only supply or come in contact with the lungs, but also the liver. Those are the two main organs that are affected by, and the digestive system, sorry, the three main organs that are affected by this condition. Commonly present with a failure to thrive, one of the common signs that will be listed, but just failure to thrive in and of itself does not always equal cystic fibrosis. You must have the other things that are listed here. So failure to thrive, dry hacking cough. This next one is a telltale sign, progressive to large amounts of sputum. These patients, the sputum is so thick that it's like nothing you've probably ever seen before until you've dealt with cystic fibrosis patients. They will have dyspnea on exertion, muscle weakness, and clubbing due to the chronic condition. Initial suspicion of diagnosis usually based on clinical symptoms and a family history. As you know, cystic fibrosis is genetic, so it is passed down from mom and or dad. Diagnosis confirmed based on 2 positive sweat chloride tests. That's important that you remember that. Just one sweat chloride test greater than 60 milliequivalents per liter does not definitively diagnose the patient. They need to have 2 positive sweat chloride tests in their chart in order to confirm the diagnosis. And they must both have results greater than 60. Chest x-ray resembles COPD, which obviously means air trapping. Barrel-chested, increased increased AP diameter, all those terms that go along with a chest x-ray that is indicative of a chronic obstructive disease. The way that we treat cystic fibrosis is to make sure that we're cleaning out the pulmonary toiletry. So pulmonary hygiene is very important. As I mentioned earlier, their secretions are so thick, and if we don't go in and help them expel that, either by teaching them how to do deep breathing and coughing, huff coughs, using an acapella, or some type of positive expiratory pressure device, a PEP therapy device, then they could get in a world of trouble if they are not utilizing those techniques on not just a daily basis, but several times throughout the day. Bronchodilator, if they have bronchospasm going on. A mucolytic, of course, you know what a mucolytic is used for, to thin out those mucous membranes. Postural drainage, of course, if they are accumulating mucus, we want to be able to get it out of those lower segments, so you want to drain it. Percussion, that helps to loosen up the secretions so that they can be more mobile. Of course, these patients need oxygen. And most typically, when they are having an exacerbation of their condition, they will be on continuous O2 therapy. Antibiotics are very important because usually the reason why they have an increase in their mucus production, they're always going to be they're always going to be full of mucus all the time, but it gets worse when they have an infection. I mean, really, really bad. Greenish yellow secretions instead of the clear looking secretions, and it will be super thick. So antibiotics is very important to give these patients when we know they have been exposed to some type of bacteria or virus. High protein diets and fluids, so these patients need very good nutrition and they need to remain hydrated. As you know, anyone with secretions, if you don't hydrate them, those secretions will dry up, and that's not good because dried secretions become retained secretions, and retained secretions do nothing but cause more infection. and atelectasis and hypoxemia and all those things that go along with having mucus in your airway. Enzyme replacement therapy, it's typically a treatment of choice depending on how far along the patient is in their disease process. Pulmozyme or Dornase alpha, you should always, always, always associate this drug with cystic fibrosis. All cystic fibrosis patients will be on Pulmozyme, and the MBRC may give you both or may give you one or the other, Pulmozyme or Dornase alpha, but as you know, it's the same drug, so make sure you know both names. And of course, that is to reduce the viscosity of the purulent secretions. Okay, for croup on the MBRC exam, they usually call it laryngotracheal bronchitis. As I stated earlier in the croup lecture, it is upper airway obstruction due to subglottic swelling. Very important for you to understand. It is the swelling above the glottis. Below, sorry, supra is above, below the glottic opening. Usually not severe, common in ages 6 months to 3 years. Common cause is RSV or influenza, which is why the patient will usually present with a history of mild infection or cold for the past 2 to 3 days, so 48 to 72 hours. And this is considered a gradual onset. Acute onset goes with epiglottitis. Gradual onset goes with croup. And with croup, as they gradually start to have signs and symptoms, those signs and symptoms will get progressively worse when the patient exerts themselves, gets agitated, or even early in the morning, because when you're resting, you're not as readily clearing your airway as when you are awake and alert. So when they first wake up in the morning, they got all these secretions that's been sitting there waiting and ready to come up and out of them. So it could cause their signs and symptoms to present poorly first thing in the morning. You're going to perform a PA chest x-ray on this patient, meaning that they need to go to the x-ray department. This is not an bedside chest x-ray. They need to be standing up or be in an upright position where their arms are on top of the cassette, up and out of the way, so that we can see their chest. Now, actually, it says chest x-ray. That should be neck x-ray, but they're going to be standing in the PA position, and you're going to be looking at their neck because you're looking for the steeple sign. Technically, when they perform this procedure, they're still going to put the patient in the same position as they would a chest x-ray. They're just going to have the cassette placed a little higher on the chest cavity, and the x-ray, instead of shooting right mid-center of the chest, it's going to have the rays focus more in the neck region. But you actually see the chest cavity as well as the neck. But once you get the x-ray, you're going to be looking for that steeple sign. And I pointed that out already in the previous lecture when we talked about croup. Symptoms include inspiratory stridor, a barking cough. The MBRC will, I guarantee you, they're going to use the term barking cough. The patient may be hoarse. They're going to be using their accessory muscles. They may be tachypnic, also have tachycardia, and maybe febrile or mildly febrile. So the way that we treat them, of course, is to address the stridor, because that's what their main issue is. We fix that stridor, everything else will fall into place. But the key is to determine whether the stridor occurs at rest. If they are presenting with stridor and they're just laying there in the bed, then they will be hospitalized so that we can aggressively monitor them and administer medications. Otherwise, if they just start to stridor when they get real agitated or worked up, or if they get up and walk about or run around and want to play, and then you start hearing the stridor, then they can go home with croup. It is not emergent. And we send them home with instructions on how to monitor the child and what medications to give and what therapies to perform. Now, when the patient has to be admitted, the way that we treat them, if the distress that the patient is experiencing is mild to moderate, they'll simply be in a med-surg unit. We'll put them in a mist tent or croup tent, 30 to 40% FiO2. The MBRC loves to call it a mist tent. It's the same thing as a croup tent, but calling it a croup tent kind of gives it away on what we're using it for. So mist tent is what they like to use. And the FiO2, again, the range is 30 to 40%. You're going to give epi, of course, via nebulization. Give steroids. Make sure the patient gets plenty of rest. And you will swab the throat and get blood cultures. If a patient is experiencing stridor and retractions at rest, not just stridor at rest, but stridor and retractions, then we're going to put them in the ICU. They need to be monitored more closer than the ones that are mild to moderate. So this would be considered severe distress if they have stridor and retractions at rest. The mist tent will be set at 30 to 40% still. Of course, you're going to use pulse ox to determine whether you need to increase or decrease your FiO2. I'm going to still administer epi via nebulizer, give steroids, make sure they get plenty of rest. You're going to also get throat and blood cultures like you did with mild to moderate distress. But the key here is you may have to intubate these patients when they are presented to you on the MBRC exam. And you will know that you need to intubate them is because they use the word marked stridor, which means nothing but severe. So they love to use the word marked to make it seem like it's something emergent or drastic. So just make sure you are aware of that. When you see that term, that means intubate them if the stridor is marked. With epiglottitis on the MBRC exam, you have to remember that the patient is going to present with a sudden onset of the symptoms. Less than 24 hours, usually 6 to 8 hours is what you will see on the exam. With epiglottitis, the upper airway obstruction is due to supraglottic swelling. So this is above the glottic. All tissues above the glottis will be inflamed. That's a bad thing because no air is getting, depending on how severe the inflammation, no air will be getting into the lungs. It is common in ages 3 to 11 years old, so you will not have any of those younger age kids with epiglottitis. In comparison to croup, which is 6 months to 3 years, epiglottitis is 3 years to 11 years of age. So these are the older kids usually get epiglottitis, and the infant to toddler age kids get croup. Common cause is a bacterial influenza. It is important to note that you take a lateral neck x-ray Important you know that it is lateral. So you turn the patient to the side and shoot the rays at the neck. And you're looking for that thumb sign on the x-ray. Symptoms include sore throat, hoarseness. MBRC loves to use the word drooling. It is very indicative of what you'll see clinically too. When patients come in through the ED and you see that kid slumped over and drooling, most typically they have epiglottitis. Inspiratory stridor, their jaw will be thrusted forward as an attempt to relieve the swelling. Tachypnea, fever, dysphagia, difficulty swallowing, dysphagia, and a muffled voice because they're trying their best not to create too many vibrations to further cause pain to their airway. Treatment: do not touch epiglottitis. That's a typo. Oh, sorry, no. It's saying do not touch the epiglottis. And they mention here that anesthesia to intubate. It depends on your facility, whether in the clinical environment, whether the therapist will be allowed to intubate a patient that has epiglottitis. Most typically, if you have anesthesia in-house, they will be the ones that will respond to these situations because they have to be able to emergently put in a trach if need be. Antibiotics need to be given, humidified O2 and even positive pressure, CPAP. Extubate the patient when you can hear air around the ET tube. That lets you know that the swelling has gone down. If you intubate these patients, most typically you don't even have to inflate the cuff because there's so much swelling going on that the airway seals to the tube. So all you have to do is every time you go assess the patient, listen to their neck with your stethoscope to see if you hear air moving. If you hear air moving, then that means that the swelling is going down. And it states that that usually happens within 3 to 4 days. Okay, the last disease we will make mention of is asthma. Make sure that you go back and look at the information that was given to you in your disease class on asthma. We will not revisit that information, but you need to know everything that you learned from last term. You know, that continues on. So everything that was taught in that course is indicative of what you need to know for this course where asthma is concerned. The only thing that was not mentioned is that on the MBRC exam, asthma is also called reversible airway obstruction, or it can be called irritable airway disease. They don't make it easy for you and call it asthma. So make sure you remember those two terms. And that is it.